Hello, my name is Amanda McCoy, and I'm a pediatric orthopedic surgeon at Children's Hospital of Pittsburgh, affiliated with the University of Pittsburgh. Today, we'll be going over lower extremity deformity. So first, we're going to look at the embryology of limb development. Then we'll talk about normal developmental limb alignment. We'll go over some principles of deformity, growth modulation, leg length discrepancy, and we'll go over a couple cases of infantile Blount's disease and adolescent Blount disease. I just want to let you know that this lecture covers a large topic, and so there are a lot of resources to learn more through textbooks and courses. And this is probably just kind of a brief overview, and if you'd like to have more in-depth learning, there are other good resources to look at as well. So starting off with embryology, as you know, the extremities are formed complete within the first 8 weeks of gestation. I know some of you guys are going back to this, you're like, oh my gosh, you have to learn this again. But as you know, the trilaminar disc forms in the 3rd week of gestation, and that goes into 3 layers, your ectoderm, your mesoderm, and your endoderm. And then your notochord expresses sonic hedgehog, which induces limb formation around day 26 of gestation. So this is a good chart. It's really for upper extremity limb development, but it's actually the same for lower extremity limb development. So as you can see that you have digital separation around 52 to 53 days of gestation. So there are multiple signaling pathways that induce limb development, and these are important because they're often tested on for test. But you have your apical epidermal ridge, you have your xanthopolarizing activity, and then you have your Wnt pathway. So let's go back to what limb development should be. So as you know, most newborns are born with approximately 10 to 15 degrees of varus. And what varus means is the terminal appendage is pointing in. So varus is bow-legged and valgus is knock-kneed. And usually genovarus is normal until about 2 years of age. And by the time you're about 2, it should correct to neutral. And then you actually go the other way. You have maximal valgus when you're about 3 to 4 years old. And by the time you're about 8, your knees should be in their normal adult alignment. So if you have persistent genovarus past 8 or genovalgum past 8, that's a time that you can consider intervening. So when it comes to the rotational alignments of limbs, generally most babies have physiologic upper and lower extremity contractures, but you have femoral anteversion, which means that your hips turn in of about 30 degrees when you're born, and they gradually derotate out to about 10 degrees. And then typically children have their tibias turning into the internal tibial rotation. And then it usually migrates out to about 10 degrees of external tibial rotation by 8 years old. I generally tell families that if you have not had resolution of inter and out swing by 8 years old, that's probably what you're going to have when you're done growing. But generally, these are well tolerated unless they're at the extremes. So in every clinic I've been to, whether it be in Pittsburgh or in Kenya, people come in for the concern of intoing. And this is just a reminder that intoing can come from the hips, the knees, or the feet. And generally, starting from bottom up, you can have metatarsus adductus in young children. And then you have tibial torsion as the most common cause of intoing in kind of toddlers age children. And then once you get older than 3 years old, generally femoral inversion is what causes a lot of intoing. And so in these pictures, an example of metatarsus adductus on this child's left foot. This is a measurement of thigh foot angle. And so this is when you measure the child prone and you measure the axis between the thigh and the foot. And this is a measure of tibial torsion as well as your supramalleolar axis. And then this is a prone examination of the measurement of hip internal rotation versus external rotation. And as I said before, if you have increased hip internal rotation, aka femoral anteversion, that can lead to intoing. So when it comes to evaluating deformities in children, it's really important to take a detailed history as well as do a detailed physical examination. So in terms of young children, I will ask about birth history, any complications, any signs of perinatal hypoxia. And then after that, I'll ask about the deformity. So how long has it been present? How big is it? Has it gotten worse? Has it gotten better? And really, how's this deformity affecting the child's development? When you look at a child from a clinical exam, you want to know where is the deformity coming from? It can be coming from the bones, it can be coming from the joints, it can be coming from the soft tissues. Is the deformity rigid? Is it flexible? Can you passively correct it to neutral? You also want to know, is there muscle spasm, spasticity, tenderness, pain? And when you're measuring clinical deformities, it's often really helpful to have a tape measure with you, as well as having a goniometer, which is pictured here. And just from a clinical standpoint, if I'm measuring genovarum in a toddler or a child less than 2, usually I'm measuring the distance between the medial femoral condyles. And if I'm looking at, valgum and an older child, and I'm measuring the distance between the medial malleoli. And that's usually predictable, so that whenever the child comes back, I don't necessarily need to get x-rays. I can clinically evaluate them. And when you think about the causes of angular deformity, there are many. Some is just physiologic, as we talked about. It's very important to know what normal alignment is and the normal development of alignment so that you can basically guide and counsel families appropriately. Then you can have deformities coming from metabolic bone disease of any cause, including osteogenesis imperfecta. It's very important to keep nutritional rickets in mind. Then you can have generalized bone disease, including melioidosis. You can have physeal abnormalities, whether that be a physeal arrest from infection or from trauma or radiation. Sometimes there are enchondromas or osteochondromas or neurophysis that can cause the physis to be a little bit thick, and that can lead to deformity. Trauma is always another one, a long bone malunion that doesn't completely remodel. There's many causes, and so it's very important to try to find the cause of the deformity before you decide how to treat it. So a lot of this comes from the Baltimore Deformity course, and if you have an opportunity, I recommend you take it if you're very interested in deformity. But a couple terms that you'll see in the literature, terms that you'll see in talks, is apex. And this is formerly known as the chora, which is the center of rotation of angle. And this is the intersection between two axis lines, right? So you have one line, you have another line, and this would be the apex, right? A line that's straight has no apex. A mechanical axis is a hypothetical line drawn between two defined points. So that's basically a line between the femoral head and the center of the distal femur. And an anatomic axis is drawn along the bone. So that could be along the tibia. So in some bones, the anatomic axis matches the mechanical axis, like the tibia. But in other bones, the anatomic axis does not match the mechanical axis. They're about 6 degrees off in the femur. So this, again, is from the Baltimore Deformity course, and this is basically the naming conventions that we have for different angle measurements. On this side, you can see this is the mechanical axis, and on this side, that's the anatomic axis. And generally, these are the normal numbers that we expect. And so basically, our goal when we're correcting deformity is to get the children to get to these numbers by the time they're skeleton mature. And we can do that in a number of ways. One way we can do that is with acute surgery, and that's osteotomies and correction. And another way we can do that with guided growth, which we'll get to next. Again, from the Baltimore Deformity course, after you know what your angle should be, you want to map the ABCs. And so you want to measure the mechanical axis deviation. And you can see that in this lower extremity, there is valgus on the right side, and there's varus on the left side. And generally, you would expect your mechanical axis to go through the center of the knee if you draw a line from the center of the femoral head to the center of the ankle. You do want to figure out which bones are deformed, and so it's really important to measure the joint angles. Sometimes you might think, oh, there is varus only coming from the distal femur, but in fact, it's also coming from the proximal tibia and vice versa. Sometimes you have valgus in the proximal tibia, but you have varus in the distal femur, or vice versa, but one outweighs more than the other, so then you have more valgus or more varus. And once you figure out what bones are deformed, then you want to measure the apex of the deformity. And that's when you draw a line, either mechanical or anatomic, and you see where those lines intersect. Oftentimes, once you figure out where the intersection is, then you can determine where you want to make your osteotomy. And oftentimes, if you make your osteotomy at the apex, then generally there's no obligate translation of the osteotomy. But keep in mind, if you make your osteotomy for biologic or other reasons, that if you make an osteotomy that is different than the level of your apex, then oftentimes you have obligate translation, which can affect bone healing or skin tension. And then once you decide where's the deformity, where you're going to make your bone cut, then you have to think about how do you want to correct your deformity. You can do it acutely, which means you fix the osteotomy acutely with pins or plates, or you can do gradual, which means you might use an external fixator. So with kids, we're really fortunate because their growth plates are open. So we often can use growth modulation to help correct deformities about the knee and the ankle. And so growth modulation is very well described in the literature. And for a child with varus knees or valgus knees, you can put a staple or a tension band plates to help tether the growth plate that is overactive to allow the slower growth plate to catch up. And so the way I think about it is when I decide how do I put the plate, where do I put the plate? One, you want to figure out which bone is deformed, but two, you have to figure out, okay, where do I want to push the bones? So if it's valgus knee, aka knock knee, then I want to push the knees out, and so I'm going to put the plate on the medial side. And if it's bow-legged, aka Gina Verum, then I'm going to put the plates on the outside so I can push in. And so generally, when you do guided growth, it's really important to continue to follow the families, because sometimes you can go too far. So you have knees and varus, and then you overcorrect, and then you have knees and valgus. And so I think it's just important to know these numbers because they help you keep in mind how long you can expect to keep guided growth plates in. And so generally the distal femur will correct about 0.7 degrees per month, and your proximal tibia corrects about 0.5 degrees per month. But when you put them together, you can get 1.5 degrees of correction. And generally correction will occur much quicker in children who are less than 10 years old. And guided growth is very good for deformities that are a little bit less than 20 degrees. When you get to deformities that are greater, sometimes you still have to consider osteotomies in addition to guided growth. It's also important to know that you really shouldn't keep tension band implants in more than about 18 to 24 months. Because if you keep them in for a long time, that can permanently tether the growth plate. And so there's a lot of literature on sleeper plates that you can explore. So when it comes to the ankle, you usually have two options for guided growth for ankle valgus, and generally you're using ankle valgus that's associated with either multiple hereditary enchondromas or another deformity. And so if you use a medial malleolar screw, which is a screw that starts at the medial malleolus and crosses the growth plate, it corrects much faster. It can correct at 0.55 degrees per month. And then you can use a tension band plate. And that corrects a bit slower at 0.36 degrees per month. But just keep in mind that you typically have more complications with medial malleolar screws in terms of breakage and removal than you would with a tension band plate, even if it has a slower correction. All right, so when it comes to deformity correction, you want to have a lot of considerations. And so you're just not looking at the bone, you're not just looking at the x-ray. You need to evaluate the entire patient holistically. And so one of the things you really want to look at is soft tissue. What is the skin quality over where you're planning to operate? Does the patient have a slick thickness skin graft that will not be that durable to operate through? Are the nerves already in tension? What's the perfusion? Is there infection or the contractures or spasticity? You also want to think about the bone. So you want to know what is the bone quality at the level of your planning your surgery. What's the bone stock? Or are there any bone loss? You want to think about what type of implants are available to you, and will they have good purchase? Again, you want to think about infection. You want to consider the magnitude of the deformity, and also you want to consider the status of the physis. So in a growing child, you might do an acute osteotomy correction, or you might do a gradual correction. But if the child is still growing, there's always the possibility that that deformity may recur. In terms of patient factors, you want to think about immune status. You want to think about nutritional status, as we talked about. A cause for bony in children is often nutritional rickets, which is vitamin D deficiency. You also want to think about social support, health literacy, functional goals, and medical comorbidities. So these are just little tricks that I've learned in my early career in terms of consideration for deformity correction. So it's not just the bone, as I said before. You want to think about, do you need to do concomitant soft tissue releases? Do you need to do nerve decompressions? And as many of you know from doing total knees in your residency, right, if you have a valgus knee and you put Tavares, that puts a lot of tension on the perineal nerve. So when you're doing acute correction from valgus to varus, oftentimes you need to do a perineal nerve decompression. And then similarly, if you're going from varus to valgus, then that can put tension on the tibial nerve. And so if you're doing a very big varus to valgus correction, like in the ankle, then you need to consider doing a tibial decompression or tarsal tunnel release. Generally, and people will vary in what they say, but large deformities greater than 20 degrees, you should consider doing gradual correction, just because sometimes that's a lot for the soft tissues to take or for the neurovascular structures to take. You always want to be mindful that there are secondary and there are compensatory deformities, whether it be in a different bone or in the same bone. You want to be mindful of the joints above and below your deformity correction. You want to know if those joints are moving well. You want to make sure that if you're planning on lengthening, there won't be any inadvertent joint subluxation or joint dislocation. When you're dealing with tight soft tissues, if you have a very tight soft tissue envelope, that's a time where you might, even though the deformity is less than 20 degrees, but because there's a split thickness skin graft over your anticipated First, you still might need to consider a gradual correction to allow the soft tissues to respond. And then if the soft tissues are tight, so say you're dealing with a distal femur deformity and you have a knee flexion contracture, so then you're thinking about, okay, should I do a opening wedge to gain length, or should I do a closing wedge to lose length? And so generally in those situations, you might want to think more about shortening, aka doing a closing wedge, as opposed to doing an opening wedge. And so just in terms of principles, the femur can be shortened by about 5 centimeters, and the tibia can be shortened by about 3 centimeters. And the reason being is because you need to maintain that muscle tension in order for the muscles to be strong. So if you under tension the muscles, aka shorten the bone too much, then what happens is the muscles are weak. And then when joints are very stiff, aka maybe like a 20 or 30-degree arc of motion, oftentimes, no matter what you do in terms of contraction releases, you cannot change that. But sometimes in osteotomy, can change where that arc of motion is to make it more functional. And so that's a conversation you want to be very detailed with patients. And these are not exhaustive, but these are things that I found very helpful in my early deformity career. And one thing that's probably the most important is that you need to plan and plan again. And it's important to ask your senior partners, ask other people what their plans would be. And so I use Bone Ninja, which is an application for the iPad, to usually plan most of my corrections. But it's really important to get input from others if you're not sure, because oftentimes deformity correction is not an acute issue. And so you really want to make sure you take time to plan the case, make sure the patient's preoperatively optimized, whether that means they need to be taking vitamin D, that means they need to go to physical therapy to strengthen their muscles and to work on flexibility. It's just really important to plan and optimize your patient. So this is just an example of a patient I took care of recently. He had a septic knee when he was younger, and that led to a valgus deformity and external rotation and patellar subluxation and a whole bunch of things. But also he had a very stiff knee and he had a flexion contracture. And so for him, I initially planned to do a 2-stage procedure. I was going to address his distal femur deformity, and then I was going to address his proximal tibial deformity as well. And this is my Bone Ninja for his distal femur. And my goal was to restore his mechanical lateral distal femoral axis to about 87 degrees, which was normal, and then work on the tibia. And so as you can see, we started about 76 degrees. I mapped my deformity. I figured out where my apex was. I made a bone cut at the apex. And because the patient had a flexion contracture, instead of going for a lateral opening wedge, I actually opted to go medial and do a closing wedge in order to get some soft tissue release to help with his knee flexion contracture. And so he healed, and you can see this is a medial plate. I actually also did a peroneal nerve decompression during this case because we were going from valgus to varus. And at this point in time, my plan was to perform a proximal tibial osteotomy as rotation. However, at this point in time, the patient says, I'm walking much better. I don't really have much anymore. I don't want to keep going to surgery. And so we stopped at this point in time. So now we're going to move on to something that's very related to deformity. We're going to look at leg length discrepancy. And there are multiple causes of leg length discrepancy. Usually you kind of think about it in like 2 to 3 big groups. So you want to think about congenital. And so when you have a congenital leg length discrepancy, usually the limbs grow proportionately, which means they will keep the relative proportion throughout growth. And so proximal femoral focal deficiency, fibular hemimelia, tibial hemimelia, or hemihypertrophy or hemiatrophy, those have the same relative proportions throughout growth. And then you can have developmental, which can come from neurofibromatosis, subfoot, and then you can have acquired, and that would be trauma, infection, post-traumatic overgrowth from a femur fracture, Blount's disease, Perthes disease. So when you're evaluating a leg length discrepancy, you want to do it both clinically and radiographically. And so clinically, I think it's very important to put a child on blocks. Oftentimes, a child will be sent to you for concern of scoliosis, but in reality, as they have a leg length discrepancy, and so then they have a compensatory flexible scoliosis, as you can see in this child. You can use a Galeazzi sign, as you can see here. You can have the child supine, and this can measure the difference in the femoral segments. And then you actually can turn a child prone and bend their knees up and measure the difference in their tibial segments. When it comes to using a measuring tape, you can measure the functional leg length discrepancy, which is a measurement from the umbilicus to the medial malleolus, or you can measure a structural, which is a measurement from the anterior superior iliac spine to the medial malleolus. In terms of radiographic assessments, the gold standard is a 3-foot standing film. Nowadays we have EOS, which is a lot less radiation and also has a little bit less parallax than your standard 3-foot standing film. And remember that parallax is when whenever your X-ray beam spread out, there tends to be aberration at the edges. And so whenever you're looking at the top or bottom of a plate, then you can have more magnification or less magnification. Also, you cannot see things as detailed because of the parallax. And so EOS actually obviates parallax because the scanner runs down. Another way you can radiographically measure ligand discrepancies is through like a scanogram. And so this also takes away the parallax. And so you basically take 3 X-rays with a radiographic ruler, and you take one center at the hip, center at the knee, and center at the foot. And so by doing this, then you can obviate the parallax that can cause some distortion to your X-rays. So the question is, if a child has a leg length discrepancy, what do you do about it? And so I think the first goal is to try to predict what that will be when the child is done growing. And so there are multiple methods for predicting leg length discrepancy. And I would say, there's some literature to suggest one's better than other, and there are a lot of comparisons. But I think the key things is if you're not sure, try a different method. And then 2, make sure that you see a child at multiple time points, because when you have multiple time points, then you can plot a curve or you can plot a line. If you only have one time point, then you cannot plot a line and you can't predict as well. And so you can use the Anderson-Green method, you can use the Millennius method, you can use the Moseley graph or the multiplier method. And whenever you use the Millennius method, which is probably the quick and dirty, easy way, it makes a couple assumptions, and these assumptions are not necessarily generalizable to other populations, because some populations have relatively delayed growth plate closure compared to the Caucasian population in America that this is modeled after. But generally, you can say that girls stop growing at 14, boys stop growing at 16. The proximal femur grows 3 millimeters per year. The distal femur grows 9 millimeters per year. The proximal tibia grows 6 millimeters a year, and the distal tibia grows 4 millimeters a year. And so that's a very kind of quick and dirty way if I'm just trying to estimate quickly in clinic where I can talk with families. But when I actually sit down and do my plans, I usually like to get a bone age, and I use the bone age and with the multiplier method. And the multiplier method was initially published by Paley and Herzenberg, but now they actually have an app, which is much easier. And so that's usually how I will predict the leg length discrepancy at skeletal maturity. And so once you predict what the leg length discrepancy at skeletal maturity will be, then you need to consider what type of treatments you should consider. And anything less than 2 centimeters is usually well tolerated. You can use a shoe lift. Anything 2 to 5 centimeters, then you're considering doing a well-timed epiphysiodesis of the contralateral extremity. Anything greater than 5 centimeters, then you're thinking about doing a lengthening. And then anything greater than 18 centimeters, nowadays, people are considering to do more lengthenings because there's a lot more technology. We have internal lengthening implants. But historically, that's when you're thinking about an ablative reconstruction with an amputation. All right, so we're going to move away from leg length discrepancy, and we're just going to go over a couple cases of Blount's disease. And so first, we're going to talk about infantile Blount's disease, and this is very common anywhere I've worked. And so it is somewhat familial. It is developmental and not congenital. And what that means is it's not present at birth, but it develops along the way. And what happens is, for some reason, on the medial side of the tibia, the growth plate becomes sick. And because the growth plate is overloaded, then it actually becomes sicker and it cannot continue to grow. And so generally, this is genovarm that is persistent in children who are 2 to 5 years of age, more common in boys, can be bilateral in 50%. Usually this is not painful, but you often will see a lot of tibial torsion. You can have a leg length discrepancy, and then oftentimes you can see a lateral thrust during the stance phase. So when I'm clinically evaluating infantile Blount's, I usually use the cover-up test. It's a very simple test, but I find it very useful in terms of trying to differentiate whether or not a child has physiologic gena vera versus infantile Blount's. And so basically what you do is you cover up the leg, and then you look at the proximal tibia. If the proximal tibia appears to be in valgus, then you can say it's probably not infantile Blount's. But if it continues to be in varus, then you want to think about getting an X-ray. And so when you get x-rays, basically you can see a lot of, you can see a fasciolysis of the medial proximal tibia epiphysis. There's often beaking and there's slipping. And then oftentimes there's compensatory distal femur valgus, which is a little bit different than adolescent blouse when you have distal femur varus. So um, one radiologic measurement that I rely on almost daily in my clinic is the genitibial metaphyseal daxial angle. And so this is an angle created by the intersection of the line of the proximal tibia metaphysis and the lateral cortex of the tibia. And basically, if it's less than 10 degrees, generally, that will almost always resolve. And so you can say it's physiologic vera. If it's greater than 16 degrees, then it's likely to progress. And so then you might be treating it as infantile bounce. And if anything between 11 and 16 degrees means that you probably should just watch carefully to make sure it doesn't continue to progress. So in terms of further imaging, whenever you're considering doing guided growth for infantile bounce, oftentimes an intraoperative arthrogram is very good to help you identify the joints so that you can appropriately place your tension band plates. MRI is helpful to evaluate the physeal bridge and intra-articular deformity. And often CT scan is not really that helpful, just because it doesn't really, as little kids, their bones are more cartilaginous than ossified, so it doesn't really show you the anatomy of the bone that well, because oftentimes it's just cartilaginous. So as I talked about before, it's really important to have a thorough differential diagnosis. You want to make sure that there isn't a physeal disturbance secondary to trauma or infection. We talked about metabolic bone disease, generalized skeletal dysplasia, and focal fiber cartilaginous dysplasia. When we look at infantile bounce, we often use the Langenskjold classification, and this was developed in 1952 in a Scandinavian population. And to keep this in mind, it's not always generalizable to non-Caucasian populations, but generally it goes from stage 1 to stage 6. And this, I feel like this classification is very helpful because it helps you determine what type of treatments you will offer. So for stage 1, in terms of treatment overview, for stage 1s and 2s, oftentimes that's just bracing. For stages 3s and 4s, that's often osteotomy. And then for stages 5 and 6, again, that's osteotomy. Recently, in the last about 10 to 15 years, we've also started to use guided growth for stages 3 and 4. So first, for stage 1 and 2, oftentimes you'll use KAFOs or HKFOs braces, and oftentimes you can use these at nighttime, but then you can do full-time wear if it's not working. And generally, you have to brace for a long time in order to watch the x-rays improve. In terms of treatment risk, risk for treatment failure, if a child has a very substantial varus thrust, aka ligamentous instability, if they're very heavy, if you start late, or if there's bilateral involvement, just because families don't tolerate it that well. Again, in an older child, that stage 1, 2, 3, and 4, if you have failed bracing, then the next thing I would consider would be is tension band plating with a lateral proximal tibia hemiepiphysedesis. And Dr. Scott was one of my mentors in fellowship, and she was an early, she published on this very early, and in my fellowship, we often had very good results from this. For higher stages, you can consider if lateral tension band plates don't work, then you would like to consider a proximal tibial osteotomy. And generally, osteotomy is performed when children are young, aka less than 4. These tend to do very well, and there's a less risk of recurrence. But in older children, even if you do the proximal tibial osteotomy, there's a risk of recurrence. It's often important to make sure that you will add a tension band plate at the same time to tether that lateral growth plate. Generally, you do want to correct to about 5 degrees of neutral alignment, and sometimes you want to consider to overcorrect to valgus. Although the deformity happens at the physis, you really can't do a good osteotomy at the physis. So oftentimes you're going to do your osteotomy just to distal to patellar tendon insertion. And it's important to do a fibular osteotomy at a separate site. And oftentimes what you do is you put in buried wires to hold the osteotomy with a cast, and then you take out the wires at a different time. And so as you go up in stages, again, you can do another proximal tibial osteotomy for stages 4 and 5. And then sometimes if you can really look at the bar of the medial proximal tibial growth plate, then you can consider doing a medial fasciolysis. It's really important if you're going to consider this that you need to get an MRI preoperatively to really evaluate the growth plate. And again, it's important to overcorrect to valgus. And for the highest stages, oftentimes, again, you're going to do a proximal tibial osteotomy, and sometimes you're just going to close the lateral proximal tibial growth plate so that you can diminish the likelihood of recurrence. And then you can just address the leg length discrepancy by performing a well-tended epiphysiodesis on the contralateral side. And then other times you can consider doing a medial hemiplateau elevation. And this is for joint congruity seen on MRI. Oftentimes in young children, you may have a downsloping medial plateau, but this will likely remodel over time once you correct their mechanical axis. So this is a patient of mine that initially presented when she's almost 5. One of my partners performed a proximal tibial osteotomy. She initially had a very good correction, but as you can see, she recurred. And then when I met her, she was about 7 years old, and you can see that she had substantial mechanical axis deviation, and she had valgus in her distal femur. She had an MLDFA of 81 degrees, and she had varus in her proximal tibia. And so what I decided was I mapped out her deformity. I found where the apex was, and then I decided to place her into a hexapod frame. And these are initial post-op x-rays. And then I actually used the software programming to define the deformity. And then the computer program shows us how we can expect the deformity to correct. I'm not sure if this is playing. See, we'll go to the next stage. All right. And then here you can see that the deformity is correcting. Well, maybe. There we go. Being a little bit futzy here. All right. So after we place our X-fix, we plan a deformity correction, then this actually prints out for the patient and for the physician. This is prescription, and it helps tell the patient how to turn the struts every day. And then this is our patient after her deformity correction. You can see this is right after we completed correction. So you can see this is her regenerate that is consolidating. And then you can see that she was here with the tibia varus right here. And then you can see here that she's corrected. Unfortunately, I don't have her x-rays yet with the frame off. I recently took off the frame, and I will get new mechanical axis alignment films to show that she's corrected. In terms of her medial plateau depression, I'm going to watch that, and then I will watch her leg length discrepancy, because at the time of surgery, I actually did take out this tension band plate and perform a completion of epiphysiodesis of the lateral proximal tibia. All right, so adolescent bounce, it's a little bit different than infantile bounce. It's basically pathologic genovarm in children who are older than 10. And it can occur in children who are obese, and it also occurs as an adolescent growth spurt. And there is some concern that maybe it is related to vitamin D deficiency. So usually it's unilateral, often in men, often in males, often associated with obesity, can be associated with SCFE, and also associated with intramuscular torsion. The difference is you don't really see the beaking that you do with infantile bounce. You actually might see some widening of the medial tibial physis. And then also, instead of having compensatory genovalgus, you actually have genovarus as well. But you can have compensatory distal tibial valgus. So in terms of treatment, you can try to lose weight. It doesn't usually work that well, and it can be difficult. And then the first line of treatment, at least in my practice, is in a child who's not skeletally mature, is a lateral tension band plates. And these can work very well. However, they can be associated with complications, particularly in terms of hardware failure. It's really important, if you're going to use these plates, that you should try to use stainless steel as opposed to titanium, because it's more rigid, has a higher modulus of elasticity. And then it's also important to use non-chelate screws, as chelate screws are a little bit weaker and tend to break more. If a child is done growing, then you can consider an acute high tibial osteotomy with internal fixation. And generally, this is good if there's less than 15 degrees of correction. And then if there's a lot of distal femur varus, then you also can consider distal femur osteotomy as well, if you have substantial distal femur varus. Another way that I typically treat this is with a hexapod or a Lizarov frame. So a hexapod frame is the overall terminology for the circular frames that use struts. Initially, it was the Taylor spatial frame, but when the Taylor spatial frame came off patent, I think about 2014, then other companies developed their own frames. And so there's probably about 5 or 6 available. And so that's why I use the term hexapod frame as opposed to Taylor spatial frame, because now it's a generic term. And so when you're placing a hexapod frame, you will do a tibial osteotomy, usually where you identify the apex, but very proximal, oftentimes because the deformity is actually at the growth plate. And then there's literature about whether or not you should perform a fibular osteotomy or not. And, there are proponents for both. In my practice, I usually do perform a fibular osteotomy. And the details of placing a hexapod frame, monitoring a hexapod frame is a little bit beyond the scope of this lecture, but I did want to expose it to you. The hexapod frames work well, but oftentimes there are pin site infections. Sometimes the frame is bulky, and then sometimes you can have slow consolidate. But if you have a tenuous soft tissue envelope, or if you have a large soft tissue envelope, I think it's very helpful. So this is a patient that presented to me with her adolescent bounce, but she's fully grown, so we didn't actually have an opportunity to do guided growth. And so I actually, given her soft tissue envelope, I felt she would be best to use a hexapod frame. And so here I mapped out her deformity and I decided where my rings would be placed. These are her post-operative x-rays. And this is the prescription put in. These are her numbers. And so let's see if this plays nicely. So you can see we did a 2-stage correction. First we lengthened. Oh no, this one's not working. Oh, there it is. Oops, kidding. Going back. All right, and then we did then we corrected the varus and rotation here. All right, so this is her when she completed her correction. And so this is where we started. This is her standing alignment film with her frame after her correction was completed. And then you can see her frame is taken off and now she has a normal knee. And we actually just did her other side. So this is a good slide from OrthoBullets that kind of highlights the difference between infantile and adolescent flounce. Key things that I think are important is age of presentation, as well as what is the femur doing. So in infantile flounce, you're going to have distal femur valgus, whereas in adolescence, you typically have distal femur varus. So this is definitely not a all-encompassing lecture in deformity, but I think it highlights a couple of principles when you're thinking about deformity. As I said before, there are a lot of courses to take. There are a lot of books, there are a lot of articles, and so this is certainly not everything, but I did want to provide an exposure to how to think about to deformity correction so that you can guide your reading in case preparation. So thank you.